when Dr. Angel phoned me to ask me to do this is a long story, but when I was a PhD student at the Institute of Medical Science, Dr. Angel was the scientific director. And I, of course, when I was admitted, had never met the scientific director or the head of the institute. And so I started. I had left my job. I had no money. And then one day the phone rang in October, and it was Dr. Angel. And he said, "Hello, Andrea." Of course, I said, "Oh, hello, Dr. Angel. You know, you just about faint, right?" And then he said, "I have good news for you. We have a scholarship." And I never forgot that. And when he phoned to ask me to do this, I thought, this is the callback. So if any of you poor graduate students need money, Dr. Angel's here today. And I did come to U of T to study decision-making at the time. Medical and nursing decision-making was my interest. And I'm pleased to say also, Dr. Dieber, I was her very first student. I'm only a couple years older than Dr. Dieber, but we're aging together and having an interesting time. I was her first graduate student. She had just come from MIT. So this is truly full circle for me today, and wonderful to be here. But what I'm actually going to talk about is, as you see from the title, thank you very much, is that following along the disparity and employment continuity, but I'm actually going to talk about health workers. Because I think, again, when we often look at these two titles, we tend to look at health delivery, and an essential part of health delivery, of course, are the people in it. We have been working for quite a while now looking at health workforce issues, mainly in the health professions, but I'm going to talk about the evolving health workers, and they're probably where the area of disparity and continuity issues may lie. So I'm going to focus mainly on home health care, sort of following up from the talk about the care of the elderly. And this is where we see a lot of emerging issues in disparities and implications for continuity of care. Just to talk about how we define things, the workforce we have, as I mentioned, we mainly look at regulated health professions, of which there are 21 in Ontario, 24 in other provinces, and we are now beginning to focus on our health support workforce this year, and I'll talk a little bit about that. We look in terms of employment, full and part-time, and working conditions, and of course this has a lot of impact on continuity of care, which is of course a great concern to all of us. When I talk about disparity, this is a term that's used different ways. But in terms of health workforces, we tend to look at dissimilarities. So how dissimilar are some of these workers within healthcare? And continuity, we talk about consistency of the characteristics of the people providing the care. So there has been a great growth. You saw the health budget. You've seen how much it has increased over the last decade in this province and actually in many provinces across Canada. And there's been a growth. And in some cases, not just a growth, but a replenishing. In 2000, we had quite a recession. There was layoffs of nurses, layoffs of registered practical nurses, and the other workforce was pretty well decimated. That was done quite dramatically, and it was recognized by governments they had to do something. So they have actually been replenishing workforces with growth, particularly in nursing and medicine, and most recently in the unregulated area. So we focus mainly in the last decade on databases. We have been working with governments and closely with CIHI to try to increase our health workforce databases. And we started mainly in 2000, 2001 working with our regulatory bodies because they actually had, every year if you're regulated you have to register. They had the information, and then we worked with them closely to try to encourage them to open some of that information. It was all closed. 2000 you couldn't go in. You could find some limited information. Now it's quite open. And we work, of course, with ministries of health around these databases, what's needed. And Dr. Dieber actually has expanded that farther. I have tended to work mainly with nursing and medicine. She's been working in a large CIHR grant, which we had as a group with laboratory technologists, midwives, et cetera, to try to build these databases of their registrants, who they are, how old they are, what they're doing, what were their conditions of work, so that we can understand and put these types of bits of information together for a variety of stakeholders. So and I won't go over this slide, but we all know the Canadian Institutes for Health Information, and this is a very, very important national resource for us as researchers. And they aggregate data sets on 27 occupational categories. It's pretty good, but it's not as good, as, of course, as researchers as we'd like it, but it's still, it's a great attempt to try to, if you want to compare nationally or interprovincially. They collect mainly on supply, distribution, numbers relative to population, employment status, and remuneration. These aren't completely full databases in every province, but in Ontario, that's what we're working towards. And I just put this one in not to discuss this slide, but this is an example of the type of data that we now have sitting at the Ministry of Health in Ontario. You'll notice it says somewhere on here confidential. I guess I took that part off, sorry. Oops. Why it's confidential, I have no idea, because actually, it wouldn't take, you can get it elsewhere. But this also, the ministry is working with us to look at the number of nurses per population, the number of doctors per population, the number of nurses per LIN, the number of doctors per LIN, just to get a sense of distribution. Doesn't tell you much else. It tells you also growth. But this is the type of cumulative data that will be collected on an annual basis from here on in. And this is just an example of a slide where we've been tracking employment with registered nurses, and we also do registered practical nurses. Why is it of interest? It's of interest going back to the continuity issue, not so much the disparity issue, the continuity issue, because in 2000, 60% of the workforce was part-time. And that was quite alarming. It actually sort of was under the radar, and it was, for the RPN, it was 30% were full-time, much lower. So why was it an issue? It was a huge issue in SARS, because when SARS came and hit the province to try to find out where the workforce was, who was caring for the patient, how was the disease being transmitted, lo and behold, they found all these healthcare workers, which are now called contingent workers, actually by sociologists, working part-time. So there was one nurse, she was working in 3 hospitals. She was a young mother, she had 2 kids. She had to make a full-time living, and she was unfortunately one of the persons who became afflicted with SARS, and she died. And those cases were very well written up in the Walker's report. So several doctors and several nurses died during that, and that's when the province became very interested in the workforce, like how healthy was it, what did it look like. And that's where we began to work with the province on trying to establish a certain, what we call 70% full-time nursing workforce in the province. It goes up and down now. The province have made an annual investment in that workforce. Full-time, we believe full-time workforces are important in continuity. Is there any actual scientific proof if you have the same person or you actually know who's caring for you? No, there's probably no scientific proof in the terms of how we think of basic science. But there's an intuitive, we all know, if your mother or father, Dr. Sinha was talking about it, the same person comes and cares for your family members, you get to know them, they get to know you. So full-time work or regular work doesn't have to be necessarily 5 days a week, but same worker, same person, seeing the family we think is very important. So we push this very hard using this data. The other area that I just wanted to address today is the emerging workforce. Who are they? And what I call it the evolving disparity, if you like. This is a program of work we're starting with our group, led by Dr. Whitney at U of T, where we're talking about the invisible workforce. We have applied to CIHR for funding. Hopefully we'll get it. But to find out who these people are, and the demographics, the survey, et cetera, and so forth, because they're large. We don't know the numbers, but they're probably as large as the regulated workforce. We don't know, but it's a goodly number. This is the type of nomenclature you see now. It's the unregulated caregivers, the health support workers, the personal support workers, the health care aide, the long-term care aide. David, there's actually a mental health aide as well. And the list goes on. It's about 15 definitions long. Who are they? What do they do? What do we know? we don't know very much. With this grant, there is a survey. We're starting with PSWs. It's unfortunately, well, I suppose it's a democracy. It is voluntary, so we won't get the full complement. You see, with the doctors and nurses, et cetera, and so forth, we have them all, because in order to be registered in Ontario, in Canada, you have got to fill out your annual form, and that's a really great value to researchers, as it turns out. But these other types of categories, they're not regulated. There is no database. It's held with employers. So employer to employee, it's very tedious to go from employer to employer to find out how many. But you saw in the paper, perhaps in the Globe and Mail, our Minister of Health made a $3 million investment only 2, 3, 4, 5 months ago in personal support workers. All of a sudden, you see schools pop up. You see, because their course can be anywhere from 6 weeks to a month, more than 6 weeks to 3 months. Highly varied education. And they're launched out into the workforce without much tracking and they have workforce issues themselves. You've seen in the paper, they're the most poorly paid. They're $12 an hour. Many of them have to travel from home to home. When I was a nurse with the VON years ago, I always was paid for my gas. They are not paid for gas. Many of them walk, and they're mainly women, and they're often women new Canadians. So this is, again, an issue of disparity, and they are providing a lot of important health care to the citizens of Ontario, and something we should be looking at. So again, what does the data tell us, and why is it important? It's really important because of concepts of continuity and disparity in health human resources are very important for us as researchers. We know a lot, as I said, about the regulated workforce, and we have a proliferation of evidence to say that interdisciplinary care is very important. There's lots of evidence. I mean, there's been study after study. There's many articles. But what is interdisciplinary care now? It actually can involve in the home six workers, if you like: physician, nurse, respiratory technologists, PSW. Sometimes it has now a medical assistant. I mean, you can have 6 people in your home, and that is interdisciplinary care. But what does it mean in the home? You know, probably very confusing for the patient. So we need to have information about who the teams are and how they work together. And we definitely need to continually address disparities, a variety of disparities within the healthcare workforce. So I'm going to conclude with that, and we left a few references of some of the articles we've written on the subject. So thank you very much.